got some great abstracts, both of you, and I just wanted to actually kick it off with a question, and if you have any questions, please feel free to come up to one of the microphones. So, Eddie, do we need to biopsy every patient with functional GI disorders to make sure that they don't have some sort of eosinophilic disorder?
Let me tell you, based on this study, you better biopsy them. First of all, I think that clinically, most of the time we do, because people look for H. pylori, of course. So in every patient that have upper GI symptoms, we look for H. pylori, we take the biopsies. The only difference here is a bit more, let's say, systematic. And the biopsy they took is both second portion and third portion, and 3 from the fundus, 2 from the antrum. I have to say that given that I do biopsy for H. pylori, and I also take biopsies for celiac in patient, I don't see these results. Yeah. And I think that, and our pathologists are quite good. I don't think they're missing. So that's the reason I say it's very intriguing. This is a huge number. But it's definitely worth, at least as a practice, for everyone to really give it a shot, do that for a while and see what you get. Yeah.
But I think, as you suggest, you could do pretty easily retrospective studies, because there have got to be huge amounts of pathologic data out there, and show that I think our anecdotal experience is that isn't the case. Rarely with IBS functional patients, and you biopsy the duodenum, you'll get mild eosinophilia, and they'll say, could it be drugs, enteric infection? Maybe now we have to add this into the mix. But the prevalence of 45% in supposedly unselected patients is...
Right. And you notice they're now applying that medication to EOE, and if it's going to follow the EOE, we're going to see plenty of these molecules like happens with EOE following and everyone developing, except this is so far considered a very, very rare entity. Unless it will change.
Dr. Sofer, I have a real problem with the study. From Mayo Clinic and Tally all the way to UCSD in San Diego, a total of only 550 initial participants, and they could only generate 181, out of 10 centers it looked like that were participating in this. Plus, I agree with you. I don't think my pathologists are that bad that they miss that much eosinophilia. And for many different reasons, I worry about the inclusion criteria, how long this study was conducted. I mean, I generate 55 patients myself a month, minimum, with this kind of condition that I do endoscopy on. And if I'm one of, it doesn't make sense. I'm sorry.
I think the value of the studies, if anything, kind of raise awareness, and it could be that in your practice and anyone else's practice, you will find out that nothing is borne out, and it's really not the case. But it makes us aware that perhaps there's something there. Yeah.
Thank you.
You're welcome.
Dr. Yadlapati.
Thank you. Thank you both for great presentations. So you both alluded to the importance of lung preservation for lung transplant patients. I'm just curious, in your practices, how do you use physiologic testing to guide who gets a fundoplication, or how you manage their reflux?
I can go first. Yeah, pretty aggressively. Almost everybody gets high-resolution manometry, endoscopy, and 24-hour pH impedance. Typically off medicine, but if they're already on medicine and have reflux, they get it done on medicine. And it's interesting, the transplant surgeons are very aggressive with fundoplication in people who do have reflux, and that decision usually is outside of us. I'm basically just saying whether or not there is reflux, yes or no, and our transplant surgeons are wrapping many patients, and even to the point with the scleroderma patients. They'll just put a peg in case they develop pretty severe dysphagia, but they're very vigilant and aggressive. So we do pretty much everything. We don't do esophagram on everybody, but I think with the EGD, the FLIP, the high resolution manometry, and the pH impedance testing, it's a pretty good workup. I don't know what you guys do, Eddie.
Yeah, they get evaluated. The transplant surgeons send their patient to the GI motility lab for evaluation. We do most of the workup, and I agree, not necessarily a barium swallow on everyone. Patient that found to have excess reflux, if they can undergo an anti-reflux surgery before the transplant, in other words, they're not so sick that they cannot have that, will have that operation before. Those that cannot and are too sick will have the transplant, and within about 6 months, and this is pretty established, will have an anti-reflux surgery. I have to say, they don't normally operate routinely on patients that do not have excessive reflux.
Can we
Only
throw
on
it back
those
to
that
you,
have excessive
Rena,
reflux.
and say, at UCSD, obviously you're doing the studies, what is then the outcome for the surgeons?
Yeah, I was curious because I think this is not really protocolized across institutions. I think everyone does it a little bit differently. So we get manometry, pH testing. It might be pH impedance or 96-hour wireless pH. Generally, if the acid exposure is over 4%, they will want a fundoplication. If the patient's healthy enough to get it beforehand, they do a fundoplication before the transplant.
Ali?
Great talks, thank you. So question for Dr. Sofer, and actually Reno is here too, about the reflux band. One issue that I have had is with that band is compliance and also the tolerance of the patients. I can't get them to wear it. Are there any tricks to it, and practically what can we do to make them tolerate it?
Well, I can, the best one to answer is probably Rena, because I have not used this one. I can only tell that there was only a dropout of about, I think, between 36 to 31 between phase 1 and phase 2, which tells me that the tolerance was reasonable. Rena, can you comment?
Yeah, I think it's a great question. When people initially see the band, they think of it as a choker around the neck. How could anybody tolerate it? I think what's very fascinating is the patients that actually had reflux to begin with, that truly have LPR, they tolerate it just fine because their symptoms actually improve. So it's actually a way of almost weeding out. But there are like maybe less than 10% of patients that just say it's very uncomfortable, they don't want to wear something around the neck, and they won't go forward with it.
Have you used it?
Yeah, I mean, I did one of the first pilot studies with Rena, and it used to be called the Razor Band, for many of you know, and I jokingly said that we should take the Z and flip it and make it the Rena Band, and just put a scarf around people's necks as the control, so they'd have the Rena versus the Razor Band. I think it's odd because the patients, a lot of these patients have a lot of functional symptoms, globus, this irritable laryngitis, and it is amazing to me that they can tolerate it at all. But they seem to do okay. But it is certainly something that many people do complain about, and they stop using it.
You know, we have one question here just in the chat. Maybe I'll just ask you, John. It says, can you comment about the validity of mucosal impedance probe during endoscopy to diagnose GERD, EOE?
Yeah, so I think the data looks really good in EOE. I think certainly when you look at the mucosal changes, they're pretty consistent. We've been working on it. You know, we've had a lot of issues just with technological stuff. I do believe there's definitely validity in the approach. I think that you are picking up something that is important in mucosal impedance. I know the company's been going through iterations and changing the devices. So I think it is something that has promise. I'm not using it clinically yet because we're still studying it in one of our trials. But it makes sense that there is this patient population that has a permeability issue that is not picked up on upper endoscopy that does correlate with symptoms. And that's really what we're looking at it for. The data, though, in EOE does look really good. I mean, if you look at the changes that you see on EOE, they're pretty obvious. So, we're definitely hopeful.
Great. Thank you both so much.
Thanks, guys. Okay, it gives me great pleasure once